Hello, good morning, and thank you so much to Ethos for their kind invitation. It's always a pleasure to be in Athens. I compliment my fellow colleagues here on the stage. And I have to say that it's always great to be back, and I've been coming more and more frequently because my training is as an infectious diseases doctor. And since I got into Parliament, I've been fighting for many causes, among which have been HIV, but also viral hepatitis. And over the last 3 years, we've been overwhelmed within our health systems with a change of paradigm when it comes to hepatitis C, as many of you may know. There are financial challenges there, but also health challenges because we have come to a point where we can cure a chronic disease that actually leads to cancer or can actually kill people. And in Portugal, we were capable of developing a major consensus that led to an elimination strategy. And today, since our program was approved, almost 10,000 people are already under treatment, of which more than 3,000 have been cured. And so it is possible within financial constraint settings to make a change. And that is a positive message I'd like to leave here, and to say that we have to do that together, bringing together politicians, bringing together physicians, academics, and also patients, putting them at the table so that together we can make decisions. Today, based on your program, we have to speak about sustainability. That's a major challenge, and both our countries share common challenges. And so I was very lucky that the colleague from IBM spoke before me, because the last part of my presentation would be about cognitive computing, so I can cut back on that. He's explained it very well. And I'll speak before that a bit about value-based healthcare and precision medicine in the future. But before that, just to say that I come from Portugal, from a small town called Cascais. As you can see, I have a very difficult life back home, and it was very difficult to make it here. I almost didn't come because I just had a baby. And I was very lucky when he became 4 weeks old, he told me he's a Benfica fan, so I'm very happy about that. So Portugal has been evolving incredibly. Since 1979, we have a national health system, which is paid mainly by taxes, and since then, life expectancy at birth has been growing. Infant mortality rate, which was at sub-Saharan level, is now a world reference. And even in my field, HIV and AIDS, we've been showing amazing results. And our national health service is based on a universal coverage citizen-centered approach, which has a tendency to be free of charge. And so when we look at how much we are spending per capita on health, we're right next to Greece there, below OECD average. However, you know these guys. We already kicked them out. I think you still have them around, which is the Troika. And that led to a lot of financial cuts. We see here, compared to the OECD average, where most health budgets kept going up, in our country we got severe cuts. If you were to compare this to Greek cuts were 4 times bigger than the ones we got in Portugal. So we face similar challenges. However, when we look at our health indicators, we are doing, despite spending less than most OECD countries, Portugal and Greece are actually doing better. Well, at least until now. To be serious about this, we know that the cuts that we have suffered over these last years, the repercussions will be seen over the next decade. We will have to wait and see. But looking at this study, which I highly recommend that you read from the Economist Intelligence Unit, it put Portugal and Greece at the top tier, when they compare how much you spend compared to your health indicators. So that means you have good healthcare professionals. That means that you have a good basis to work on. But you need to make sure, like we do, we have to do the proper reforms. And look at this OECD study. It applies to any OECD country as Portugal, as Greece, where basically in Portugal we're spending around 6% GDP in health, but by 2060 we're going to spend significantly more. The question is if we're going to spend more in a sustainable way, or if we're going to achieve a point where we cannot continue to spend the money we are spending, and basically we'll start to have to cut services. And The difference is if you're capable of implementing the needed reforms to achieve that sustainability or not. It is not realistic to say that you can do everything and do not have a plan to make it sustainable down the line. When politicians like to speak about life expectancy at birth, especially because everybody is normally getting better. If you look at Portugal or Greece, we're probably almost at the level of Norway or Sweden. However, when we look at health life years at birth, that's where things get complicated. In our older years, as we approach the moment of death, our last years of life have much worse quality than in the northern Scandinavian countries. And that applies for Portugal as it does for Greece, and it is worse for women than it is for men, which means we have a system and that is not prepared to make people healthier as they grow older. And then when you look at the demographic evolution, this could almost be a copy of the Greek demographic evolution because you're suffering the same thing. And Portugal, for example, 2/3 of the population will be over 65 years of age in 2050, the oldest country in Europe. You're suffering from the same consequences. If even today people are not having a quality of life in their older years, how is this going to work in the future? And then we have the chronic diseases issue. Mary from Ireland told you about that. 86% of European budgets are spent dealing with chronic diseases, reacting to chronic diseases, not preventing them, reacting, treating. When you see diabetes, in Portugal it's now at 13%. Of our 10 million population, 1.3 million have diabetes. Here in Greece, you're already almost at 9%. We have to do something to change it, especially because diabetes is not just a disease. It's a reflection of a social condition. And that means that there are things that we can do that go beyond health. And then the lack of human resources. We are both suffering from the same difficulties, maybe for different reasons. In Portugal, we have a lot of people retiring. So we're going to have over 1 million people in 2021 that will lose their family doctor. Now, when we look at Greece, because of the financial impact, we've seen an exodus of healthcare professionals to other countries, ironically, many of which to Greece. How is this going to impact your health system in the future? That is a question also for sustainability. And the question here every politician has to make is, do we believe in the European social model? I do. And I think it's the best way to have a humanitarian approach to health, in which we believe in a universal coverage, in which we believe in equity and access, in which we offer high quality of healthcare and solidarity in funding. These are important principles that we must all agree on so that we can move forward. But speaking of health and sustainability, we have to go back to basics. Medicine started here. You guys started it all. And the first doctors came out of Greece. And when we look back, the principles of medicine were very simple. Promote health, preserve health, restore health when compromised, and minimize suffering and malaise. This is what a doctor, a nurse, a health professional is trained to do. However, it seems like we forgot that over the years. In the 19th century, with the Industrial Revolution, important change happened. This allowed us to evolve, to develop as nations. We grew to prosperity that we had never dreamt about before as a human race. However, over these last over 100 years, we see that the way we manufacture, the way we think, and from a managerial perspective, has not changed that much. Look at Model T at Ford in the US, and 100 years later, building Priuses in the Toyota car plant in Japan. And Toyota became very famous because they started implementing models of management that made them highly efficient, like the lean management. And so in the 70s and the 80s, there came this trend among healthcare professionals where, why don't we apply management tools from car plants in hospitals to make hospitals more prospective? And thus we have evolved to the industrialization of medicine, in which we pay doctors and we pay hospitals, and managers are given bonuses based on the number of surgeries they're capable of performing, based on the number of hospital visits, based always on quantitative measures on a production perspective. However, that does not make people healthier. Our goal as healthcare professionals, as health institutions to make people healthier. And there are places where we are spending our money poorly. This is from the US. It could be applied to any health system in the world, in the Western world. We are wasting money with overtreatment, with failures to coordinate care, with failures in care delivery, excessive administrative costs, excessive healthcare prices, and fraud and abuse. And this all leads to our incapacity to reduce the burden of disease. Well, when we speak about sustainability, WHO has a very good plan. They basically say start at the top of the pyramid, reduce low value-added healthcare, then reduce excessive margins without reducing healthcare, and then, of course, invest in efficiency, in structural reforms, and in health promotion and prevention. WHO actually tells us health promotion and prevention should be the base of all of our health systems. However, in Europe, all countries are spending less than 3% of their health budgets to approach public health approaches. So what we are doing is we're spending more than 97% of our money, of taxpayers' money, to react, to treat diseases. So we do not have health systems. We have disease systems that are trying to survive. And this is a very old slide that it is very important for us to never forget. Social determinants of health determine our health status. As I will show, 60% of our health status depends on these determinants. Where we live, our education, our employment status. What Mary said is extremely important, and we must understand that health, to be efficient when it comes to health policy, you have to depend on many ministries, not just your health ministry. And everybody has to agree on this common goal of making people healthier. There has been many studies on how to achieve that sustainability in the long run. Michael Porter published in Harvard the Value Agenda, which I think has a very good premises. And he said in his studies that in healthcare, the days of business as usual are over because of chronic diseases, because of the raising costs of innovation and technology, the need for more qualified healthcare workers, the demographic pressure, social inequities, and the raise of the burden of disease. And so what Porter and his team defend is that we have to move from this industrialized view in which we have healthcare systems organized around what physicians do, to make sure that the systems are centered on the patient, organized what the patient needs, what the patient expects, which means you have to start asking the patient those questions. Focus on the volume and profitability of services provided. So this focus that we used to have, where we used to pay based on visits, pay based on number of surgeries, towards a system based on patient outcomes, in which we pay based on patient outcomes, on which we pay managers and give them their bonuses based on achieving patient expectations. And we have to change this fragmented system in which all of us are closed in our own silos toward a network that is organized around particular medical conditions and concentrated in health delivery organizations. It's the value agenda. And you can see the study, and he basically organizes it this way, in which you have these organized units based on different medical conditions. You're able to measure outcomes and costs for every patient. You're capable of then moving towards bundled payment on the whole cycle of care, integrate care across facilities, and expand throughout geography so everybody has access. And to do this, of course, you have to have a very strong technological platform. So in very simplistic terms, what we are talking about here is changing where the carrot is today for managers in the hospital, from that industrialized view where the carrot was, if you get more surgeries done, you get more money, towards moving the carrot to where the patient is. If your patient gets healthier, then you get paid. But I think that view is insufficient. I think we need to go a step further to achieve true sustainability. Because with this system, in the way most health systems are built, we will end up seeing hospitals choosing the best patients, artificially making sure that their statistics are good. So we have to move towards putting the carrot in the middle of the community, making sure that hospitals and managers are responsible for the health of every individual within their region, within their community. If you have a patient with diabetes that has not been diagnosed, it is your fault. But if you have a patient with diagnosis that you have been capable of controlling or even preventing, then you should be paid for that. It is a major change within the mindset of healthcare management, but this is the only way we're going to start spending money, instead of just bureaucratic, industrialized processes, to actually make people healthier. That is what healthcare systems have to do. That's what they were made for. And so value is a simple equation. It's health outcome over the cost, being the cost, how much money you spent, be it euros, dollars, or pounds, and the outcomes based on quality, efficacy, and safety. Look what happened here. So this is a practical example of where value-based healthcare has been applied. It's on prostate cancer surgery. And I have the averages from Germany, Sweden, and the Martini Clinic in Hamburg that has applied this value-based approach. When you look at the survival rate after 5 years on the left side, you see they're about the same, 94–95% survival rate for prostate cancer surgery. Okay. But then when you look at the 1 year incontinence, so patients that have urinary incontinence 1 year after, 50% in Germany and Sweden, 1 year after the surgery, only 6.5% at the Martini Clinic. And when we look at erectile dysfunction, which is a big deal for the patient, 1 year after, almost 80% in Sweden and in Germany, 34% at the Martini Clinic. The difference is simple. When they operate their patients, they have queries, surveys. They ask the patient, what is your expectation for this surgery? And then they assess the outcomes based on those expectations. And they do these kind of surveys year after year. And guess what? They pay their doctors based on those performances. Not based on industrialized views on just getting the surgery done, but on how effective that surgery is, not only in survival, but actually giving better quality of life to the patient. That makes a difference, and there are proven track records to show it. Unfortunately, we have a lack of outcomes. The paucity of outcomes data leads to lack of information. Since we're so much focused on the process, we assume that measuring the process will make the outcome better, which is not true. Outcomes are hard to compare because we don't have standardized outcome measurements, and so it's hard to learn from each other, and we're not focusing on the patient. And so if you don't focus on the patient, you never measure success based on patients' needs. And that's why ISHOM was created by Harvard, Karolinska, and the Boston Consulting Group, and they're working on standardizing health outcomes so that everyone can measure them and transform the financing models of their health systems to be based on these outcomes, as we saw at the Martini Clinic. And the last aspect we've spoken about before, and so I'll go through this very quickly to end, is the technology. We need this technological platform to push us forward because, as was shown, the evolution of information is growing so fast, and that line you see crossing over there is the human capacity to assimilate that information. We have reached a point where it is impossible for us as doctors to assimilate more. 60% of one person's health depends on social factors and exogenous factors, 30% on genomics. So only what we do every day in the hospital, what we do in the clinic, is only responsible for 10% of the person's health. So we need to incorporate all of this information. And it has been proven that we are all different, and that's where precision medicine is going to bring us important information, because we are living today on a trial and error basis. We are testing daily with our patients. And that's why when you look at the number of patients who fail first-time use of drugs, 70% of our Alzheimer's patients fail on the first time they use drugs, 70% of cancer, 50% in arthritis drugs, 40% of depression. We have to acknowledge the need to personalize. And that's where the genomics will play a role. I will not spend much time on that, but we will have to evolve, because 10 years after sequencing the human genome, we do not have the knowledge, education, or informatic tools to implement any of the omics in true terms. Predictive and personalized medicine and informatics really needs to be a research and education theme in its own. And the truth is, our informaticians, if you work in a hospital or a clinic, you know that. Even your informaticians that work with you are not prepared for this new stage. And this needs to be changed. Because when we see this, and this is from IBM, I have no conflict of interest with them after the previous speech, just to show you that we have evolved our health systems. Most of you have a computer in your health clinic. Basically, today still, it's just a substitution for paper. People basically write down whatever they see, and they have it in a digital format. And now we're about halfway in the exchange phase, where we're actually looking at images, we're able to share information among colleagues. However, we need to move towards the end, towards that advanced clinical decision support tool that the information technology is now capable of doing. And to get there, I agree with the previous presentation. It will be through artificial intelligence. It will be through cognitive computing, which is basically the simulation of human thought process. And the Watson was shown here, and that is one example. Google, Microsoft, Dalto in France, to show a European example. We have many corporations working together towards finding solutions that can help us create these decision support tools. And the importance of what was spoken before, the natural language, the capability of generating hypotheses and to adapt and learn is so important. And one last aspect I'd like to speak about that my previous colleague didn't is not only does it include all of the information that it is published, it does something that as health professionals we highly appreciate. It uses something they call patient similarity. It looks for patients that are similar and learns from what each patient is doing. We are having real-time, real-world trials in which we can learn in that real-world manner, and that will help us move us forward. If we improve health, we will improve care, and we will reduce cost and waste. And so, sustainability in healthcare systems and making people healthier are compatible and needed if we want to believe in health as a development tool for any country to evolve in the future. Thank you very much.